Hi guys, welcome back again. Today I'm gonna talk to you about the ECG interpretation, and here we have a lot of cases. We will discuss each one. Here we have sinus tachycardia. Sinus tachycardia result from increased SA node discharge. If you look at this ECG, here we have PQRS complex. This is PQRS and T. This is PQRS T. If you look at this ECG, here we have rhythm. Rhythm is regular. Because of that, here we have a regular rhythm. So the rate, why we say it's irregular? If you look at this one, this is R to R is equal in duration from R to another R of the QRS complex. Here it's normal and regular rhythm. Okay, so because of that, the rate we will calculate as a 300 over R to R interval. Here we have R wave. Also here we have R wave. How many large square you have? It's about 2 large square. So we will divide 300 over 2. It's equal 150, or we can say more than 100 beat per minute. P wave is normal, upright, uniform. Yes, it is upright and uniform. It means that there is upright and uniform. Upright and uniform. It's just like this. It's regular. All of them. Okay. PR interval is normal also. QRS normal also. So as I discussed in the previous video, the rate is fast. Why? Because it's more than 100 beat per minute. Rhythm is regular. P wave is normal. PR interval normal. QRS normal. So this is called sinus tachycardia. Here we have some important notes that we have to know. Sinus tachycardia may be caused by exercise, anxiety, fever, hypoxemia, hypovolemia, or cardiac failure. Here also another ECG which is called sinus tachycardia. Why? Because the rhythm is regular. Yes, it's regular. Okay, the rate more than 100 beat per minute, so it's called tachycardia. If you look at this one, here we have R to R interval between the QRS complex. How many large square we have? It's about 2 large square. So 300 over 200 is equal 150. So it's called tachycardia, or we can say more than 100. PR interval is normal also. PR interval is it's about 3 to 5 small square or 1 large square, as I discussed before. QRS complex also normal duration. ST segment is isoelectric. It's not ST elevation here, or not depression. Okay. T wave normal, conduction normal, electrical pathway. Here we have sinus bradycardia. Sinus bradycardia result from slowing of the SA node. Here we have slow rate. Because of the rhythm is regular, so we divide also 300 over how many large square we have? It's about 1, 2, 3, 4, 5, and 6. So here we have 6 large square. So 300 over 6 is equal to 15 beat per minute. Or we can say less than 60 beat per minute. So it's called bradycardia. But it's regular in rhythm, isn't it? Yes, it's regular. Here we have P waves also. P wave is present and normal, regular also. Okay. PR interval is normal also. QRS normal. Okay, here we have clinical tip. Sinus bradycardia is normal in athletes and during sleep. In acute MI, myocardial infarction, it may be protective and beneficial, or the slow rate may compromise the cardiac output. Certain medications, such as beta blocker, may also cause sinus bradycardia. Here we have atrial tachycardia. So what's atrial tachycardia? A rapid atrial rate overrides the SA node and becomes the dominant pacemakers. Some ST wave and T wave abnormalities may be present. Here we have an example for atrial tachycardia. If you look at this one, here also is rhythm is regular. Okay, because of that we calculate rate 300 also again over to our interval. So if you look at this one, it's about 1.5 large square. Okay, so 300 over 1.5 large square is equal to 200 beat per minute. P wave also is normal. Okay, PR interval may be short, less than 0.12 seconds in rapid rates. QRS complex is normal. Here we have SVT, or supraventricular tachycardia. This arrhythmia has such a fast rate that the P wave may not be seen. So here P wave is absent. Okay, so here because of the rhythm is regular again, so the heart rate is calculated by 300 over R to R interval again and again. Okay, so the rate is about 150 to 250 per beat per minute. The rhythm is regular, P wave frequently buried in preceding T wave and difficult to see. So PR interval usually not possible to measure. Why? Because there is no P wave to measure PR interval. Okay, QRS is normal. SVT, supraventricular tachycardia, may be related to caffeine intake, okay, nicotine, stress, or an anxiety in healthy adult. Here we have Wolff Parkinson-Wise syndrome, as I discussed in the previous video. In Wolff Parkinson-Wise, an unnecessary conduction pathway is present between the atria and the ventricle. Electrical impulses are rapidly conducted to the ventricle. Okay, this rapid impulse create a slurring of the initial portion of the QRS called delta wave. If you look at this one, this is called delta wave. Okay, this is delta wave. This is delta wave. The rate depends on the rate underlying rhythm. If it's regular, okay. Because of it's regular, so again and again 300 over the PR to R interval. Okay, regular unless associated with atrial fibrillation. Why? Because there is a irregularity or irregular rhythm. So at that time, we, as I discussed, we calculate the heart rate as a 6 second or in 30 large square. We calculate the R in QRS complex and then multiply by 10. Okay, here we have P wave is normal. This is P wave is normal, upright and uniform. Okay, this is P wave. Okay, unless atrial fibrillation is present. PR interval is short. Why? Because here we have PR interval, it's about 3 to 5 or what we call 1 large square. But here, if you look at this one, this is P, this is our PR interval is short, less than 0.12 seconds. If P wave is present, QRS is wide. If you look, QRS is wide in Wolff Parkinson-Wise syndrome, more than 0.10 seconds. Delta wave present. Here we have sinus arrhythmia. the SA node, sinoatrial node, discharges irregularly, okay, and the RR interval is irregular, okay. If you look at this one, this is R to R is not equal to R to R interval, okay. This is the first R to R interval, this is the second, it's not equal, okay. And again, here to here is longer than the here to the second, this is the third, so it's called irregular rhythm. So the heart rate is calculated by enumerate the 30 large square and then account R in QRS complex during 30 or 6 seconds, okay. And the rate usually normal, about 60 to 100 beat per minute, frequently increase with inspiration and decrease with expiration in sinus arrhythmia. P wave is normal, upright and uniform, okay. QRS is normal and PR interval also normal. The pacing rate of the SA node varies with the respiration, especially in children and elderly people. Here we have SA block. In the SA block, the block occurs in some multiple of the P and P interval. After the dropped beat, cycles continue on time, okay. So if you look at here we have R to R interval, so but this is equal, but from here to here it's not equal to here, so it's called irregular rhythm. And if you look at here, this is P, Q, R, S, T, but there is no P and Q, R, S complex also. So the rate is normal to slow, determined by duration and frequency of SA block. The rhythm is irregular, as I said, whenever the SA block occurs. P wave normal, upright and uniform, okay, except in area of dropped beat. It means here it's abnormal, okay. PR interval is normal, QR is normal. Cardiac output may decrease, causing syncope or dizziness. Here we have right bundle branch block. If you look at here we have lead 1. In the level here we have slurred S wave, okay. If you look at the V1 and V6, here we have rabbit's ear in shape, just like that, okay, in V1, while in V6 is slurred S also, okay. So ECG criteria for right bundle branch block, QRS is more than 0.12 seconds, slurred S in lead 1 and V6, RSR or notched R in V1, it means here, okay. This is RSR, okay. As I mentioned before, here we have SA node, AV node, bundle office, and is divided into right and left, but here totally impaired, okay, block in right bundle branch. This is the ECG changes in right bundle branch block. If you look at this one, here we have left bundle branch block, okay. Here we have criteria which is called Scarbosa's criteria. Here we have ST elevation more than 1 millimeter in lead with a positive QRS complex, or ST depression more than 1 millimeter in V1, V2 or V3. But it's easy to memorize that. Here we have W in shape and M in shape in V1 and V6. If you look at the V1 and the QRS complex, it's just like W in shape, and V6 is just like M. It's called left bundle branch block. This is left bundle branch block. Here we have a problem and there is no conduction, okay. ECG pattern in viscous are is R's criteria. Okay, and in V1 it's just like W, in V6 it's just like M. Here we have something in order to know that is it a left bundle branch block or right bundle branch block, okay, which is called William and Marrow. Okay, the first letter is W, it belongs to V1, QRS complex just like that, W in shaped, and M shaped in V6, so it belongs to left bundle branch block. So if you look at the V1, if it's just like W in shape and V6 is just like M in shape, so it belongs left bundle branch block. On the other hand, here we have marrow. In the marrow we have the first letter is M shaped in V1, and okay, if you look at this one, this is M shaped and V6 is just W in shape, so it belongs to right bundle branch block. Here we have Stemi and Nstemi, ST elevation myocardial infarction and non-ST elevation myocardial infarction. I discussed in the previous video. So as you know, here we have isoelectric line, there is a ST elevation. Okay, here we have evolution of Stemi, ST elevation myocardial infarction according to the minute to hour, 0 to 12 hour, 1 to 12 hour, 2 to 5 days, weeks, months, and persistent ST. Here we have normal. This is the normal ECG. Hyperacute T wave minutes to hours in ST elevation. If you look at this one, this is hyperacute T wave. Okay, in the 0 to 12 hours in evolution of ST elevation. Okay, if you look at this one, this is ST elevation. Here we have Q wave developing over 1 to 12 hours. This is pathological Q wave. Okay, here we have ST elevation with T wave inversion in 2 to 5 days. This is ST elevation and T wave inversion. T wave recovery weeks to months. T wave is normal. Here we have persistent ST elevation. Okay, also it's another picture of ST elevation. As you know, it should be more than 2 millimeter in chest limbs and more than 1 millimeter in limb leads. Peaked T wave. If you look at this one, and there is small or indiscernible P wave. Okay, there is small or indiscernible P wave. So this is called hyperkalemia. Increased potassium. Okay, here we have first, second, and this also subdivided into the type 1 and type 2 morbidity, type 1 and type 2 second degree and third degree AV block, as I discussed in the previous video. But P wave before each QRS identical and PR interval more than 0.20 second, and QRS complex also more than 0.12, and characteristics regular rhythm. If you look at this one, this is a regular rhythm, so there is a characteristic of first degree AV block. Here we have prolongation of AV conduction, P wave presence, precedes each QRS complex, PR constant but exceeds the upper limit more than 0.2 second. Rate is normal, rhythm regular with constant prolonged PR interval. If you look at this one, this is a constant PR interval. PR interval, prolonged PR interval. Okay. Here we have second degree AV block, morbidity type 1. As I discussed before, here one or more of the atrial impulse failed to reach the ventricle. Progressive prolongation of PR interval followed by missing QRS complex. Rate is normal, rhythm is regular, atria irregular, ventricle. Here we have P and P. There is no QRS complex. Here we have prolonged PR interval. There's a normal, but there is a prolonged PR interval. Okay. Here we have second degree AV block morbidity type 2. One or more of the atrial impulse fails to reach the ventricle. Constant normal PR interval followed by missing QRS complex. It means that there is a normal PR interval, but there is no QRS complex. Okay, so again here we have PR interval is normal. The rate is normal, rhythm is regular, atria irregular or regular ventricle, depend on the AV block. Okay, here we have third degree AV block. Atria and ventricle are depolarizing independently, no association between atria and ventricle. So here we have the problem, if you look at this one, if the problem is here we have P, Q, R, S, T, and there is a prolonged PR interval. Okay, and here again we have P and then T, then followed by P. So there is no association between the atria and ventricle. Okay, so here we have T inversion, here P to P, there is no QRS complex. Again here we have P and P wide of the QRS complex, and T wave also here inverted. Here we have P to P wave, and there is no QRS complex again. So there is a collection of AV first degree, second and third degree of AV block. Here we have a quiz for you. Hope you can diagnose the problem. What are the ECG changes? Okay, the first one here, the first ECG, hope you can diagnose. The second ECG, the third ECG, the fourth ECG, and the fifth ECG. And that's all about the ECG. I hope you got a benefit from this video. Thanks for watching.